It's Andrew Kramer, Urology Associates, Cape Cod, showing you penile implants, and, well, we've got another tough one, complicated one. I'm going to show you what it is. He comes in from out of town, and he feels he's got a bulge, or what we call an aneurysm, on one side, and also he's lost some fluid, it's not pumping all the way up. Can we fix it? Sure. We're going to do our normal revision routine. This video is longer because I need to show you what we're going to do is repair the corpora or do a corporoplasty due to stretching from the aneurysm. So we do a remove replace. Now he's a big guy. He's got he's heavy set, and he's got also a lot of length and girth and things on the edges. Very short pins, very long pins, very thick. These are harder than just the sort of average dimensions. In this case, it's going to take a lot of pumps to inflate this large girthed implant, and we're going to pump it up. We feel automatically that that right cylinder at the base, sort of proximally. Now, last video I did a week ago, there was a large distal aneurysm that needed a larger repair. This one is more proximal, so base of penis over on the right, and we don't know. The big first question is it the cylinder or is it him? Could be either one. Now, the last patient, we took the cylinders out, and the cylinder was normal, yet he had developed a corporal ballooning or aneurysm due to maybe some trauma from a prior procedure. So anyway, this is going to be different. We're going to take the cylinders out, right and left. For some reason, I don't check the cylinder right away. I'm caught up in sort of the progressions here, but I will test them soon. I'm going to measure and dilate, and incidentally, before he had a 21-4 as far as sizing and rear tips. We're going to upsize him to actually a 24-2.5. That means he's going to gain centimeter and a half, which is good, and also larger implant alone and less rear tips. So in that regard, we do get more length, but still the principal problem is not solved yet. What we're going to do now is expose buccal fascia. So it's all the way at the base. Don't need to do a circumcising incision, fortunately, but we do have to expose that corpora on the bottom here, base of penis. We have it exposed, and I think, well, hold on. We need to see, was it the cylinder, was it his penis, and decide what it is, so we go from there. We're going to take the new device. We're ready to put it in, and at this point, I'm thinking, will that solve it or not? Let's test the prior cylinders. This is on the left side, so we're not worried about that, but I'm going to inflate it artificially just with a syringe, backfill it, and left cylinder's good. Great, no problems there. I'm going to take the right, and this is where the aneurysm was. Is it his body? Is it the cylinder? Well, it's the cylinder. Look at that. It is not just his body. The cylinder was defective. That's what had the aneurysm. Different than the last surgery where cylinder was fine, but he himself had it. This is forced due to a defect of the cylinder from, he's had it 8 years and loved the implant, but a weak spot developed, exploited it, became a balloon, aneurysm. And what happened was that aneurysm alone started out with normal penis and normal corpora, but over time of stretching, his body then, his corpora developed a bit of a ballooning itself, a little bit of an aneurysm, but not nearly like the other surgery. I'm going to fix it, though, with a corporoplasty. So new implant is in, and at this point, what you need to do is put the new implant in. It has to be done over the inflated cylinder, and then we're going to pump them up and see if we feel anything, because the new cylinder is in, the old one was defective. Maybe this fixes everything, but we know we can fix these corporal issues, and unless it's perfect, we're going to lean toward fixing everything, and that's what happens. We pump them up with the new cylinders, and though not nearly as profound, I feel at the base a bit of ballooning, a bulge, and outpouching, and say, well, I'm going to sort of tubularize or do a repair of the corpora on the right, where the balloon has been pushing open the corpora. So I, at this point, say, well, let's do that corporoplasty. We need to. So what I'm going to do is pump it up, feel the balloon. A balloon is not even 10% of the way the other was. First things first, I feel like the cylinder's not long enough. It was short on the right. It always was short. So I'm going to do my normal routine, which is scissor a little bit more distally and add more rear tip. When the suture falls off, you can just use a 3/0 Vicryl stitch to replace the little stitch that enables you to use the furlough. It's not a major issue if that pops off. It does in this case. Just takes a minute. Cylinders now in, new cylinders. And while you don't want to permanently close, you have to close. You have to suture, close the corporotomy, because you're going to pump it up, and then you're going to show whatever pathology there is So you're going to need to close it to inflate it. By the way, also, another step, you need to replenish and top off all the fluid in the device. So, well, we've opened it, we removed cylinders, we drained fluid. So I drain everything out of the system and refill the reservoir, 100 cc's in his case, more than enough. But you've got to account for that. You can't forget the step. I'm going to go ahead, clean off Buck's fascia, use a sharp scissors, then I'm going to mark off where his body is forming a little bit of that aneurysm. And his body, it's right here, or base of penis on the right, and what I'm going to cauterize right over it. And that's the next step. If you use cutting current at a low level, 20 for example, in the cautery, you will not injure the implant. And then Corporal's open, his body's got the ballooning. What I'm going to do is put stitches in and go deep in that tubular structure, and then deep to the other side, so narrow there. See, the stitch goes in deep into the incision at the bottom of it, and then I'm going to sew it to deep on the other side. Here, I'm going to put a series of these. When I tie it, it'll take what was wide and make it now narrow. And what I want to do is tubularize the right to make it the same size girth as the left. You put in a series of stitches. Don't suture it till the end. These stitches will take a broad aneurysm and narrow it and tubularize it. That's a corporoplasty. And I think this is better than a graft because, low risk of infection, and all you're trying to do is narrow. He's got good tissues, but stretched. I'm going to go for the inside of one, inside of the other, tighten it, and then we'll sort of plicate or imbricate it, we call it, to narrow what was a ballooned out aneurysm. It was ballooned out because the cylinder was defective, nothing to do with his tissues, but over time, inflating an aneurysm created a bulge, and now I pump him up. He's now straight. The tip on the right is better. It's more optimal than it was for the last 8 years. I've topped off his fluid, and I fixed that major issue, which was the aneurysm at base of right side of penis using a corporoplasty. He already is pain-free. He didn't have many issues during his recovery. Felt fine. Dissolvable stitches on the dartos and skin. Home without any issues. Andrew Kramer, Urology Associates, Cape Cod. Thank you so much.